Hi, welcome back. We're doing part 3 of chapter 12, nursing care for patients having surgery. Page 190, nursing process for post-operative patients. A complete patient assessment is performed after transfer to the nursing unit. Respiratory status, vital signs, including temperature, level of consciousness, surgical site, dressings, and pain level are noted. IV site, patency, and IV solution and infusion rate are monitored. NG tubes are hooked to suction and or clamped as ordered. Drains and catheters are positioned to promote proper functioning. Interventions to promote recovery are implemented. They include monitoring for complications, for example, respiratory depression, hemorrhage, and shock, and providing postoperative care. Additional interventions are reinforcing teaching to patients and their significant others and assisting with necessary referrals, including providing home health care. Respiratory function, data collection. Regular monitoring of the patient's respiratory system is done. This includes rate, depth and effort, and breath sounds. Cough strength, if not contraindicated by the type of surgery, such as hernia repair or eye, ear, intracranial, jaw, or plastic surgery, is also noted. Postoperative patients are at risk for developing atelectasis. This can lead to pneumonia. They may have a weak cough from being drowsy from anesthesia or analgesics. Listen for fine crackles in the lung bases. If present, encourage the patient to deep breathe or cough. Listen again to see if the crackles have cleared. If the patient's airway is compromised, take immediate action to support the airway. Notify the surgeon. Nursing care plan for the postoperative patients. Nursing diagnosis. Ineffective breathing pattern related to pain. Expected outcome. The patient will maintain normal arterial blood gases and oxygen saturation levels at all times. Evaluation of outcome. Are arterial blood gases normal? Intervention. Give analgesics per pain scale rating as ordered. The rationale promotes willingness to deep breathe as patient does not guard against deep respirations or coughing, especially if the incision is near the diaphragm. Evaluation. Does the patient perform deep breathing and coughing? Nursing diagnosis. Ineffective airway clearance related to ineffective cough and secretion retention. Expected outcomes. The patient will maintain a patent airway at all times. Breath sounds remain clear at all times. Evaluation of outcome. Is the patient able to clear own secretions? Are breath sounds clear? Intervention. Monitor breath sounds. Rationale. Abnormal breath sounds such as crackles or wheezes can indicate retained secretions. Are breath sounds clear? Encourage deep breathing and coughing hourly and use of incentive spirometer as ordered while awake. Lung expansion and coughing helps prevent mucus plugs that block bronchioles, causing alveoli to collapse and atelectasis or infection to develop from stasis of mucus, resulting in pneumonia. Does patient perform deep breathing and coughing and use incentive spirometer? Ensure that patient's pain is relieved before activity. Movement can cause or increase pain. Does patient state that pain is controlled before activity? Encourage movement by turning every 2 hours and early ambulation as able. Movement promotes lung expansion and movement of secretions. Is patient moving? Geriatric. Ensure adequate hydration. Older adults are prone to dehydration, making their secretions thicker and more difficult to clear. Does patient have balanced intake and output? Nursing diagnosis. Acute pain related to tissue damage from surgery, muscle spasms, nausea, or vomiting. Expected outcome. The patient will report pain management relieves pain satisfactorily within 30 minutes of report of pain or when the patient awakens. The patient will describe pain management plan by first post-operative day. Evaluation of outcome. Does patient report satisfactory pain relief? Is the patient able to describe pain management plan? Intervention. Explain pain relief interventions and set goals with the patient for pain management. Rationale. Patients are partners in their pain management and need to understand the plan to collaborate on the goals. Evaluation. Does patient understand the plan and have a goal for acceptable pain level? Monitor pain using a patient appropriate pain rating scale, self-report 0 to 10, non-communicative, you could use a pictogram, pain assessment in advanced dementia, which is pain ad, see chapter 10. Self-report is the most reliable indicator of pain unless the patient is unable to report pain. Is the patient using a pain scale? Provide ordered pain medication as needed. Analgesics, along with other types of medications, decrease pain along various pathways. Is patient's pain reduced after receiving medication? Provide antiemetics as needed. Antiemetics relieve nausea and vomiting. Is patient's nausea and vomiting reduced after receiving medication? Position patient comfortably. Incisions, drains, tubing, equipment, and bed rest can cause discomfort, which positioning can relieve. Does patient report positioning is comfortable? Geriatric. Monitor patients who are cognitively impaired immediately at the beginning of shift and then frequently. Cognitively impaired patients are vulnerable to undertreatment of pain and deserve excellence in pain relief management. Does patient exhibit signs of reduced or no pain per pain scale? Use pain rating tools designed for cognitively impaired patients to assess pain regularly and observe nonverbal pain cues, for example, restlessness, grimacing, and moaning. The pain of older patients, especially if cognitively impaired, is often underreported and undertreated. Noting nonverbal cues can aid in pain treatment. Are nonverbal pain cues present in older patients, especially those who are cognitively impaired? When monitoring pain, speak clearly and slowly so older patients can hear and understand. If older patients cannot hear or misunderstand, pain may not be reported accurately. Appropriate intervention would not be provided. Is patient able to report pain and relief accurately using a pain scale? Nursing diagnosis. Risk for surgical site infection related to inadequate primary defenses from surgical wound. Expected outcome. The patient will remain free from infection at all times. Evaluation of outcome. Does the patient remain free from infection? Intervention. Observe incision for signs and symptoms of infection. Report if present. Rationale: redness, warmth, fever, and swelling indicate infection. Are signs and symptoms of infection present? Maintain sterile technique for dressing changes. Sterile technique reduces infection development. Is incision free of signs and symptoms of infection? Geriatric. Monitor for and report low-grade temperature or new onset confusion. Older adults may exhibit low-grade temperature or new onset confusion as indicators of infection requiring treatment. Does patient have low-grade temperature or new onset confusion to report? Circulatory function. Page 192. Data collection. Monitor the patient's circulatory status to detect and prevent hemorrhage, shock, and venous thromboembolism. Vital signs, oxygen saturation, and skin temperature, color, and moistness are monitored per institutional policy. Report abnormal findings. Check the incision or dressing for drainage or hematoma formation. Drainage may leak down the patient's side and pool underneath the patient. Turn the patient if able, or while wearing gloves, slide hands underneath the patient to check for bleeding. Report any signs of hemorrhage or shock promptly. Observe the lower extremities of surgical patients. Check peripheral pulses and capillary refill. Tenderness or pain in the calf may be the first indication of a deep venous thrombosis, DVT. Leg swelling, warmth, and redness, as well as fever, may also be present. Bilateral calf and thigh measurements are taken daily if DVT is suspected or diagnosed. Nursing diagnosis, planning, and implementation. Deficient fluid volume related to blood and fluid loss or NPO status. Expected outcome. The patient will maintain blood pressure, pulse, and urine output within normal limits at all times. Monitor dressings, incisions, drains, and tubes for color and amount of drainage, and report bright red drainage or excessive drainage amounts immediately to detect hemorrhage. Monitor intake and output to detect imbalances. Maintain IV fluids at the ordered rate to maintain fluid volume. Ineffective peripheral tissue perfusion related to interruption of blood flow during surgery, dehydration, and use of leg straps. Expected outcome. The patient will maintain normal tissue perfusion at all times. Encourage leg exercises hourly while patient is awake to prevent venous stasis and thrombosis. Avoid pressure under the knee from pillows, roll blankets, or prolonged bending of the knee, and elevate legs to help prevent venous stasis. Use elastic stockings or an intermittent pneumatic compression device as ordered to help prevent stasis of blood. Thigh-length stockings are more effective than knee-length stockings in reducing the risk of thrombophlebitis. Assist with early post-operative ambulation as ordered to prevent thrombosis. Give anticoagulants as ordered to reduce clot formation. Evaluation. The goal for deficient fluid volume is met if vital signs and urine output are within normal limits. The goal for ineffective tissue perfusion is met if tissue blood flow remains normal. Postoperative pain. Pain is very common after surgery. Each patient's pain experience varies, incisional pain, and painful muscle spasms can occur. Nausea and vomiting, ambulation, coughing, deep breathing, and anxiety can increase postoperative pain. Unrelieved pain has negative physiological effects. It impairs deep breathing and coughing. Early ambulation is more difficult. Increased complications, length of hospital stay, and healthcare costs can occur. Pain should not be ignored or undertreated, yet it has been found that it often is. Evidence-based guidelines to manage postoperative pain have been developed. Increased use of multimodal therapies, for example, different medications and routes, non-pharmacological therapies, is encouraged. This allows lower doses of opioids to be used and results in fewer side effects. Pain treated along with various pathways provides better relief. The use of acetaminophen or Tylenol and NSAIDs should be considered. Stay informed of advances in pain management. Make pain relief a priority in providing excellent patient care. It will reduce patient suffering and promote a quicker recovery. See Chapter 10. Data collection. Monitor nonverbal indications of pain for patients who are not fully awake. Nonverbal indicators of pain may include restlessness, moaning, grimacing, and rubbing or pulling at specific body areas or equipment. Ask patients who are awake about the location of the pain, to rate the presence of pain, and to describe the pain qualities such as sharp, aching, throbbing, or burning. Findings are documented. Gerontological issues. Postoperative pain. Pain is not a normal part of aging. Careful identification of older patients' unique aging changes, chronic diseases, and pain relief needs is required to appropriately treat their postoperative pain. Cognitively impaired adults are at risk for undertreatment of their postoperative pain. Make these patients a priority to observe and provide pain relief at the start of your shift and then throughout it. Pain rating scales are available for use for those who are cognitively impaired to determine if they are experiencing pain. Refer to consultjerry.org for additional pain assessment tools. All right, so I clicked on that link and it took me here to hign.org, the Hartford Institute for Geriatric Nursing. And there are several things here. There are some e-learning modules. And also, this is a Try This series. It offers assessment tools on a variety of topics relevant to the care of older adults. So check it out. Okay, this is the bottom of page 193. Urinary function, data collection. Monitor the patient's urinary status. If the patient has a urinary catheter, note the amount, color, and consistency of the urine. Otherwise, monitor for the patient's first post-operative voiding within 8 hours of their last voiding. This is to prevent urinary retention and bladder distension. Patients having urinary or gynecological procedures may need to void within 4 to 6 hours. This prevents increased pressure on the surgical site. Urinary catheterization may be needed if the patient is unable to void. Epidural anesthesia and narcotics may cause urinary retention. After outpatient surgery, patients may be required to void before being discharged. Critical thinking. Mrs. Wood, age 42, returns to the surgical unit after a hysterectomy. Her post-operative vital signs and assessment findings are normal. Mrs. Wood rates her pain level at 9 and the nurse notes that she moans occasionally, repeatedly moves her legs, and pulls at her covers near her abdominal incision. She is drowsy but repeatedly says it hurts. In the anesthesia care unit, a patient-controlled analgesia pump (PCA) was started. The last dose of medication was delivered 45 minutes ago. What nonverbal pain cues does Mrs. Wood display? Moaning occasionally, moving legs restlessly, and pulling covers near abdominal incision are nonverbal pain cues. Number 2, how should the nurse document Mrs. Wood's pain? Document pain levels by actual observations, occasional moaning, restless leg movements, and pulling of covers near abdominal incision. Also, use the patient's statement, "It hurts," because Mrs. Wood is too drowsy to use the pain scale. Other data are used. When Mrs. Wood is more awake, an explanation of the pain scale should be reinforced and used. Number 3, what action should the nurse take to relieve Mrs. Wood's pain? Encourage patient to use patient-controlled analgesia (PCA) button if there is pain. Reinforce teaching on the PCA pump as able. Administer additional multimodality medications as ordered. Also, consider other pain relief measures such as patient warmth and positioning, as well as environmental issues such as bright lighting, room temperature, and noise. Number 4, when should the nurse next monitor Mrs. Wood's pain level? And the answer is in the top of page 200. After the PCA pump is pushed by the patient, monitor pain level in at least 30 minutes to determine pain relief. If Mrs. Wood is asleep, she should not be awakened unless it is necessary. Nonverbal cues should be observed. Count respirations and document. After Mrs. Wood is more alert, PCA monitoring is done hourly or per agency policy. Number 5, if Mrs. Wood indicates that her pain remains unrelieved with the PCA pump, what action should the nurse take? Which team members will the nurse collaborate with? Document pain level, such as on a scale of 0 to 10. Collaborate with a surgeon for report of inadequate pain relief. Nursing care tip. Anticipate the post-operative patient's pain. Regularly assess pain level. Do not wait until the patient asks for the next dose of pain medication. This approach is essential to provide excellent pain relief. Monitor the patient using a patient-controlled analgesia (PCA) pump, including the patient's ability to use it, response to the medication, and relief obtained from the medication. Monitor for respiratory depression, hypotension, or other side effects. If PCA is not effective or if side effects occur, notify the surgeon. Promote comfort with positioning and warmth. Attention to environmental factors such as bright overhead lighting, excessive noise or visitors, and extreme room temperatures also helps promote comfort. Give antiemetics as ordered to relieve the discomfort of nausea and vomiting. If vomiting occurs, turn the patient onto one side to aid emesis removal and prevent aspiration. If a patient reports the inability to void, palpate the bladder for distension. Perform a bladder volume measurement as ordered. This will determine the amount of urine in the bladder. Restlessness can be caused by discomfort from a full bladder. A distended bladder requires intervention to empty it. Efforts are made to promote voiding. Inserting a urinary catheter is the last option because of the risk of infection. The sympathetic nervous system is stimulated by the surgical experience. Fluid is saved by reducing urine output. Initially, urine output may be reduced and concentrated. Then it should gradually increase and it will become less concentrated and lighter in color. Critical thinking. Mrs. Owens returned from a bowel resection 2 days ago. She is receiving 1,000 milliliters of 0.9% normal saline solution over 10 hours on an intravenous IV controller pump. At what rate will the IV controller pump be set? Well, 100 milliliter per hour is what we will set it at. Intravenous pumps are always set to deliver the amount of milliliters per hour. Divide the total volume of 1,000 milliliter by the total time of 10 hours to equal 100 milliliters per hour. How many milliliters should you record as intake for 12 hours? So the intake is an 8-ounce cup of coffee plus 4 ounces of juice plus 6 ounces of soup, 3/4 of a cup of gelatin, 2 cups of water, and 1,000 milliliters of the IV, the 0.9% normal saline solution. And the output for 12 hours was 1,700. So the intake was 2,400 milliliters because we know that there is 30 milliliters in each ounce. So 1 cup is equal to 8 ounces. So the coffee, we had 240 milliliters. We did 8 ounces times 30 milliliters per ounce. For 4 ounces of orange juice, 4 times 30 means that is 120 milliliters. 6 ounces of tomato soup is 6 times 30, which is 180 milliliters. 2 cups of water, 3/4 of a cup of gelatin would be 3/4 times 8 times 30, which equals 180 milliliters. 2 cups of water would be 2 times 8 times 30, and that gives you 480. And we did give in the 1,200 milliliters, so if you add those up, it comes to 2,400. The patient's output does not reflect the intake total, so it is not used for this calculation. Nursing diagnosis, planning, and implementation. Acute urinary retention related to surgery, pain, anesthesia, and altered positioning. Expected outcome. The patient will completely and regularly empty bladder. Measure and record output on postoperative patients, especially those undergoing major procedures or urological surgery. Older patients and those with IV or urinary catheter to detect urinary elimination problems. Report urinary output of less than 30 milliliters in 1 hour from the urinary catheter because this is typically the minimum acceptable output. Recognize that patients who are voiding small amounts frequently, 30 to 50 milliliters every 20 to 30 minutes, or who dribble may have retention overflow and may not be emptying their bladder. This pattern may require catheterization to empty the bladder and prevent complications. Assist patients to the bathroom or bedside commode and allow men to stand or sit to urinate if possible to promote voiding. Warm bedpans to prevent reflexive sphincter tightening. Use techniques to promote voiding before catheterization for patients who are unable to void. For example, warm running water, or just running water, pouring warm water over a female patient's perineum, or drinking a hot beverage to stimulate voiding, because catheterization increases the risk of infection. Provide privacy after safety is ensured to promote voiding. Have the patient place their feet solidly on the floor to relax the pelvic muscles to aid voiding. Notify the physician if a patient is uncomfortable, has a distended bladder, or has not voided within the specified time frame to obtain treatment orders. Evaluation. The goal for urinary retention is met if the patient is able to void without pain or complications. Surgical wound care. An incision is a wound made by a surgeon with a sharp instrument, such as a scalpel. A puncture wound has a small opening and is made to insert a tube or drain. Incisions are closed with sutures, staples, surgical adhesives, or adhesive strips. As the wound heals, sutures or staples are removed in 7 to 10 days. Wounds can be clean or dirty. Clean wounds are surgical wounds that are not infected. Dirty or contaminated wounds include accidental wounds or surgical incisions exposed to unsterile conditions. Infected wounds and dirty wounds contain microorganisms from trauma, ruptured organs, or infection. Necrotic and infected tissue is removed before infected wounds are closed. This is known as debridement. Wound healing. Wound healing occurs in phases. Wounds can heal by first or primary intention, second or secondary intention, and third or tertiary intention. In first intention healing, the edges of the wound are approximated with staples or sutures. This usually results in minimal scarring. For second intention healing, the wound is usually left open and it heals by granulation. Scarring is usually extensive with prolonged healing. For healing by third intention, an infected wound is left open until there is no evidence of infection. Then the wound is surgically closed. A stapled incision. Note wound edges not approximated at the arrows. For A, that would be right in here. And for B, arrows indicate puncture sites where drains were inserted. So that's what those holes are. Wound healing phases. Phase 1 has a time frame from the incision to the second postoperative day. Wound healing includes an inflammatory response, and the patient effect is fever and malaise. The second phase of wound healing is the 3rd to the 14th postoperative day. This is when granulation tissue forms, and the patient may be feeling better. In the third phase, the time frame is from the 3rd to the 6th postoperative week. This is when collagen is deposited and a raised scar is formed. Phase 4, the time frame is months to 1 year. The wound contracts and heals, and the patient effect is a flat, thin scar. Wound complications. Wound problems can include hematoma, infection, dehiscence, and evisceration. A hematoma occurs from bleeding in the wound and into the tissue around the wound. A clot forms from the bleeding. If the clot is large with swelling, the clot may need to be removed by the surgeon. Infected wounds may be warm, reddened, or tender and have purulent drainage or pus. The drainage may have a foul odor. A fever and elevated white blood cell count may be present, Antibiotics are used to treat the infection. Dehiscence and evisceration are serious wound complications. Wound dehiscence is the sudden bursting open of the wound's edges. It may be preceded by an increase in serosanguinous drainage. Evisceration is the viscera spilling out of the abdomen. Dehiscence and evisceration often occur with abdominal incisions. Those at increased risk are patients who are malnourished, obese, or older, or who have poor wound healing. To help prevent dehiscence and evisceration, support the wound during coughing and other activities that pull on the incision. Applying an abdominal binder can help reduce risk. If evisceration occurs, the patient may report that something let loose or gave way. Pain and vomiting may occur. Be safe. If dehiscence or evisceration occurs, position the patient in low Fowler position with knees flexed. Cover the wound with sterile dressings and clean towels moistened with warm, sterile, normal saline. Apply gentle pressure and keep the patient still and calm. Notify the surgeon immediately of this surgical emergency. Monitor vital signs for evidence of shock, for example, tachycardia, tachypnea, dyspnea, hypotension. Infuse intravenous fluids as ordered. Prepare the patient for immediate surgery to close the wound. For dehisced surgical incisions that resist healing, vacuum assisted closure (VAC) aids in healing the incision and other wounds. See Chapter 54. VAC applies negative pressure to wound edges. Data collection, drains. Drains are inserted into wounds during surgery to prevent accumulation of blood, lymph, or necrotic tissue in wounds that can lead to infection or delayed healing. Drains may work by gravity or suction. Penrose drains are soft, flat drains. Moderate pink, serosanguinous, consisting of blood and serous fluid drainage, is expected from a Penrose drain. These drains may require frequent dressing changes. Some drains use suction to gently enhance drainage. They include Jackson Pratt and Hemovac drains. These drains are closed systems and they may require periodic emptying. Okay, so I clicked on the link and this is what I was able to find for drains. This is the Hemovac. And let's see what else they show. Doesn't that look interesting? There's a collection bottle, wound drainage tubing, dual trocars, an evacuator, and an infection control exudate bag. So let's keep looking. They're easy to empty. This is how they're showing the process here. I see. So looks like you can empty it that way. Then there's also the mini bulb system. Makes emptying exudate easy while minimizing the clinician's exposure to blood. It can hold up to 150 milliliters. Okay, so there's that. And then they also offer these PVC drainage tubes. This one does not have a trocar, but they do make these drainage tubes also with and without trocar. So that's that one. Just a quick look at some of the other items at that website that are related to this chapter. This is a surgical helmet system that has a fan, and so you don't have to sacrifice comfort for protection. There's some tourniquets, fluid waste management, visualization, power equipment, saw blades. Here's some vascular compression therapy that improve patient outcomes and reduce the risk of blood clots associated with DVT. Wound lavage, wound debridement was mentioned. There's also skin grafting that's an option. Here's the wound drainage we looked at. They have some other orthopedic care, some boots, and also traction. So that was interesting. Output is recorded when drainage is emptied. The amount of drainage expected varies with the type of surgery. Be alert for excessive amounts to report. Specialized drainage systems allow the transfusion of drainage-containing blood back to the patient, autotransfusion. This maintains hemoglobin levels without the risks associated with blood transfusions. Dressings. Dressings protect the wound, absorb drainage, prevent contamination from body fluids, and provide comfort. They can also apply pressure to reduce swelling or bleeding, as in a pressure dressing. The initial dressing is applied in surgery. It is then often removed by the surgeon about 24 hours post-operatively. If drainage appears on the initial dressing, reinforce it with another dressing. Follow surgeon's orders or institution policy. After the initial dressing is removed, if the wound is dry and the edges intact, approximated, the surgeon can order the wound to be left uncovered. This allows easy observation of the wound and avoidance of applying tape to the skin. Draining wounds are dressed with several layers. They are changed as needed. When the old dressing is removed, it should be done carefully to prevent dislodging of tubes or drains. The condition of the wound is documented with each dressing change. It is normal for the incision to be puffy and red from the inflammatory response. The surrounding skin should be the patient's normal color and temperature. Correct tape application over the dressing is done by gently laying the tape over the dressing and applying even pressure on each side of the wound. Pressure should not be applied on top of the wound by pulling the tape from one side of the wound to the other side. Nursing diagnosis, planning, and implementation. See risk for infection related to inadequate primary defenses from surgical wound. See nursing care plan for the post-operative patient. Impaired skin integrity related to surgical incision. Expected outcome. The patient will regain skin integrity within specified individualized realistic time frame. Monitor skin color and temperature and report changes to detect the need for treatment. Monitor dressings and note drainage, color, amount, and consistency. Surgical wound drainage initially is sanguineous, red. It changes to serosanguinous, pink, and then serous, which is a pale yellow, after a few hours to days. Promptly report drainage that is bright red, remains sanguinous after a few hours, or is profuse to the surgeon because the patient may be hemorrhaging. Use standard precautions when changing dressings to protect yourself and others. Evaluation. The goal for impaired skin integrity is met if the patient's wound heals and skin integrity is regained without delayed healing or complications. Gastrointestinal function. Nutritional intake and bowel function can be affected by surgery and anesthesia. Being NPO and having a bowel prep may occur preoperatively. After abdominal surgery, peristalsis, bowel sounds, and flatus usually stop. Paralytic ileus. This may last for 24 to 72 hours. Flatus, bowel movements, and an appetite signal the return of the gastrointestinal function. Interventions to shorten ileus time include the following: minimally invasive surgery, alvimopan or entereg, 12 milligrams given in a hospitalized setting only 30 to 90 minutes before surgery and twice daily for up to 15 doses only in 7 days. Risk of myocardial infarction. This increases recovery of the functioning of the GI tract after partial, small, or large bowel resections. Early ambulation as ordered, chewing gum, early feeding as ordered, avoidance of NG tubes as complications and delayed feeding can occur. Data collection. After abdominal surgery, monitor for the return of flatus, which is gas or farts, and appetite. First bowel movement, nausea or vomiting, or signs of paralytic ileus. Paralytic ileus signs are distension, bloating, and cramps. Document the abdomen as being soft or firm and flat or distended. The patient's abdominal girth is measured if distension occurs. Report abnormal findings to the surgeon. Traditionally, after GI surgery, bowel sounds were monitored by the nurse. The patient was kept NPO until flatus and bowel sounds returned. Studies show that bowel sounds are not correlated with bowel motility and the patient's ability to safely drink and eat post-operatively. In fact, patients can be hydrated and fed early. This promotes healing and faster recovery. Nursing diagnosis, planning, and implementation. Imbalanced nutrition less than body requirements related to NPO, pain, and nausea. Expected outcome. The patient will resume normal dietary intake and maintain weight within normal limits. Maintain IV fluids, parenteral nutrition, or enteral feedings until the patient resumes oral intake. Offer water and clear liquids first as ordered, then advance the diet to promote tolerance. Give antiemetics as ordered to control nausea and vomiting. Constipation related to decreased peristalsis, immobility, altered diet, and opioid side effect. Expected outcome. The patient will return to normal bowel elimination patterns and report freedom from gas pains and constipation within 3 to 4 days post-operatively. Encourage early ambulation and exercise to promote restoration of GI function. Increase comfort by having patient lie prone and pull the knees up to the chest if gas pains occur to relieve the pain. Monitor elimination and document to detect problems. Provide stool softeners or laxatives as ordered to prevent constipation. Evaluation. The goal for imbalanced nutrition is met if patients are able to maintain their baseline weight and resume a normal dietary intake. The goal for constipation is met if patients are free from discomfort and establish a regular bowel elimination pattern. Mobility. Data collection. It is important for the patient to move as much as possible to prevent complications and promote healing. Pain incisions, tubes, drains, dressings, and other equipment may make movement difficult. You should determine the patient's ability to move in bed, to get out of bed, and to walk. Pain levels that may interfere with movement are assessed. The patient's tolerance for activity is observed. Patient understanding of how to perform exercises is identified. Nutrition notes. Nourishing the post-operative patient. After surgery, 5% glucose in water is given intravenously is commonly prescribed. 2 liters of this solution contain 340 calories. This is insufficient to meet the patient's energy needs. However, it is enough to prevent ketosis from breakdown of adipose tissue. Previously well-nourished adults generally have nutrient reserves for 3 to 4 days of semi-starvation. Prevent excessive muscle protein from being used for energy. Deliver adequate nourishment to the patient within 3 days. Boost, Breeze, and Ensure Clear are incomplete nutritional supplements. They have approximately 30 calories and 1 gram of protein per ounce. They can be used to supplement clear liquid diets as ordered. To avoid abdominal distension, oral feedings traditionally have been delayed until peristalsis returns. Scientific evidence supporting this practice is lacking. Researchers are testing this practice. Patients usually progress from clear liquids to a regular diet as soon as possible. If the diet as tolerated is prescribed, the patient should be asked, "What sounds good?" Offering a full dinner when the patient doesn't feel well may turn off the appetite. After gastrointestinal surgery, oral food and fluids are deferred longer than with other surgeries to allow healing. When specific amounts of intake are prescribed, those limits should be strictly implemented to preserve the suture lines. After oral and throat surgery, no red liquids are given. This is so bleeding can be seen and vomitus is not mistaken for blood. Specific nutrients necessary for healing include the following: vitamin C for collagen formation, vitamin K for blood clotting, zinc for tissue growth, skin integrity, and cell-mediated immunity. Protein for controlling fluid balance and edema, for manufacturing antibodies and white blood cells, and for building scar tissue. Nursing diagnosis, planning, and implementation. Impaired physical mobility related to surgery, decreased strength, and movement restriction. Expected outcome: the patient will resume normal physical activity. Position the patient in bed with pillows to support the body in good alignment. Turn patients at least every 2 hours, alternating from supine to side if not contraindicated, to prevent complications. Encourage patients to move themselves to increase circulation and promote lung expansion. If ambulation is not possible, encourage hourly exercises. For example, deep breathing, range of motion of all joints, and isometric exercises of the abdominal, gluteal, and leg muscles while awake to prevent complications. If patients cannot perform active range of motion exercises, perform passive range of motion to prevent complications. Raise the head of the bed slowly to let the circulatory system adjust to the position change. If patients report dizziness or feeling faint, lower the head of the bed to let the circulatory system adjust more slowly. Ensure patients wear non-slip footwear to ambulate safely. Allow patients to sit on the side of the bed prior to standing and pedal the feet to wake up the muscles controlling the arteries to prepare for ambulation. If a patient tolerates sitting, assist the patient to ambulate to promote healing and reduce complications. To rise, the patient should keep eyes forward and move slowly until feeling adjusted to being up. Usually, the patient ambulates a short distance the first time and increases the distance as tolerated. One or two healthcare workers should assist the patient and use a gait or walking belt for safety. Walkers with wheels and seats also may be used for support and for resting if the patient becomes dizzy or tired. If the patient feels faint or dizzy, or if vital signs change, help the patient back to bed. A wheelchair may be needed for safe transport back to the room. Evaluation. The goal for impaired physical mobility is met if the patient can increase ambulation and resume normal activities. Post-operative patient discharge. Discharge planning begins when during pre-admission testing. It is ongoing after admission. This ensures a timely discharge. When the patient meets discharge criteria, the surgeon discharges the patient. Ambulatory surgery. Discharge criteria. Usually, a patient is a candidate for discharge 1 hour after surgery if the PACU discharge scoring system or clinical discharge criteria are met. See Box 12.5. Clinical discharge criteria include stable vital signs, no bleeding, no nausea or vomiting, and controlled pain that is not severe. For certain surgical procedures, for example, urological, gynecological, or hernia surgery, the patient may need to void before discharge. The patient should also be able to sit up without dizziness. Patients meeting discharge criteria are discharged by the surgeon. They are released to a responsible adult. Patients are not allowed to drive themselves home. This is because of the effects of anesthesia and medications. Discharge instructions. Patients and their families are given written discharge instructions. The caregiver of an older patient should participate in the discharge instruction session. This promotes understanding for care and reporting of complications. The instruction form is signed by the patient or an authorized representative to indicate understanding. Send prescriptions and a copy of the instructions with the patient. Encourage the patient to rest for 24 to 48 hours. Instruct the patient to avoid operating machinery, driving, drinking alcoholic beverages, and making major decisions for 24 hours. The effects of surgery and anesthesia can alter energy levels and thinking ability. The surgeon will order fluid, dietary activity, or work restrictions. Patients are taught wound care, medication information, including side effects, and complications to report to the surgeon. Phone numbers for the surgeon, medication information, the surgeon, surgical facility, and emergency care are provided. Patients are told to call to make a follow-up appointment. Inpatient surgery. Discharge criteria. The surgeon determines the patient's readiness for discharge from the hospital. Before discharge, a complete assessment of the patient is performed and documented. Discharge instructions. Patients and families are taught wound care, medication information, and signs and symptoms of complications to report to the surgeon. If the surgeon orders fluid, the surgeon orders fluid, dietary, activity, or work restrictions, and the date for a follow-up visit to the surgeon. A copy of the signed written instructions and prescriptions are given to the patient. If further teaching or reinforcement is needed, a referral to a home health care nurse can be requested. Home health hints. A referral for home health care is made when the patient who had surgery needs skilled nursing care at home after discharge. See Chapter 16 for examples of skilled care. It is helpful for caregivers to keep a notebook in the hospital and continue it at home. Treatments, medicines, observations, procedures, healthcare provider and nurse visits, instructions, and therapies with dates and times can be recorded. When a patient returns home, the home health care nurse can provide the following guidance to caregivers for setting up the living room, bathroom, and equipment the patient will use. It is helpful if the bedroom can be on the same floor as the bathroom and kitchen. This may require temporary use of a den or living room for sleeping. For the patient on bed rest, a hospital bed with full side rails helps with a variety of position changes and provides a better working height for the caregiver. Lift sheets made of folded twin sheets are needed, as well as extra pillows for positioning and splinting. A bedside stand is needed for personal care items. A bedside commode can be placed near the bed if the patient cannot walk to the bathroom. A bedpan or urinal may be needed. A functional female urinal is easier to use than a bedpan. A handheld shower is convenient and allows the patient more independence in bathing. Installation of grab bars and tub stools, as well as skid proofing of a shower or tub, are important safety measures to prevent falls. Physical or occupational therapy can make specific recommendations. For the patient prescribed anticoagulants and/or elastic stockings, the importance of and instructions for using them to prevent deep venous thrombosis should be reinforced. Nutritional status should be monitored and reported to the registered nurse to aid wound healing. The patient and caregivers should be instructed on hand hygiene before and after wound care to prevent infection. For prescribed pain medication, pain management, and potential side effects to report should be discussed. So now we're going to look at some of the questions that are on the slides. Which of these is a purpose of surgery? Select all that apply. Is it 1, preventive, 2, diagnostic, 3, exploratory, 4, emergency, 5, curative, and 6, palliative? So they're asking about purpose. That's a very important word here, I think, because the preventive is a purpose, the diagnostic is a purpose, exploratory is a purpose, emergency is not a purpose, but curative is a purpose and palliative is a purpose. So these are the answers. Everything except for number 4. So it's 1, 2, 3, 5, and 6. The next one is, which of these describes the postoperative phase of surgery? Is it 1, the decision for surgery until the transfer to surgery? No. 2, transfer to surgery until transfer to PACU. We're looking for the postoperative phase. That is not when you're going into surgery. It would be after the operation, postoperative. Let's see, number 3, PACU through recovery. That sounds pretty good. And 4, provision of home health care. And the answer is 3, PACU through recovery, which is the post-anesthesia care unit. Okay, the next one is, which of these criteria apply to informed consent? Number 1, it gives legal permission for surgery. Yes. Number 2, informed consent, physician's responsibility. It is the physician's responsibility. That is true as well. Number 3, not sedated when signing. That is true as well. 4, voluntary. That is also true. 5, cannot be withdrawn. That's not true. And 6, valid for 3 months. Not necessarily. So that's not the case. The answer is 1, 2, 3, and 4. Which of these activities can help prevent post-operative respiratory complications? Number 1, deep breathing and coughing. Oh yes, that's great. Incentive spirometry, yes. Number 3, early ambulation. Yes, highly recommended. Number 4, leg exercises. Absolutely can help with that. And 5, hand squeezes. I don't think so. I think the answer is 1, 2, 3, and wait a minute. It's 1. Let me just check which can prevent. Actually, wait a minute. 1, 2, 3, 4. Okay. So it is 1, 2, 3, and 4. That's correct. The last one. Which of these must be included in the discharge teaching process? Select all that apply. Number 1, complications to report to the healthcare provider. You bet. You definitely need to make sure the patient knows that. Number 2, CPR training for family. Depends. Well, no, I don't think that's really part of it for discharge teaching, unless, well, it's just not. Okay, number 3, instructions provided in writing. Yes, they did say that you must also provide them in writing. 4, instructions signed by the patient/family. Yes, you need to sign them, get them to sign them so that there's recognition that they exist and that they were acknowledging receipt. Number 5, medications explained. Well, yes, you need to explain any medications before discharge. So that is part of your teaching process. So that's all for Chapter 12. I hope it has helped you.